We performed the test to assess for ischemia. It was negative. We ruled out ischemia as the cause of deterioration in the ejection fraction. And here we are seeing the echocardiography. The contractility. A scan was made, a chest CT with reconstruction of the pulmonary veins and with nothing striking except that you can see what you see at the pulmonary vein level. The microphone is choppy. I'm so sorry. It's going to be difficult to get all the translation. You can see the mechanical valve and the diagnosis then atrial fibrillation, persistent symptomatic atrial fibrillation, and mechanical prosthesis in the aortic and mitral position. So this is the case that we're doing at the present time.
Can you hear me? Can you hear me? Can you hear?
Yeah, sorry, go ahead.
Andrea, go ahead. Describe.
Shiv.
Yes, Andrea.
So this is a guy with the two mechanical valves, really very large left atrium, with some degree of scarring, especially around the posterior wall and the pulmonary vein. And so we isolated the vein, posterior wall, and we were kind of doing the part in front of the appendage, and then he went into this flutter, just with catheter manipulation.
Okay.
So this is a guy where you have to do a very extensive procedure from the get-go, because those are not patients where you can do pulmonary vein and just wait and see. I can guarantee you that these are patients that with the pulmonary vein, they're always going to come back, all of them. So you have to start to sort of a more aggressive approach.
Sure.
Usually in our experience, the most common location for additional trigger after the posterior wall of the pulmonary vein are the CS and the appendage. So we're going to start working on those two areas.
Describe eyes.
So Andrea, a quick comment about the fact that you're using electron-anatomical map mainly as a shell right now. Is that correct?
¿Qué es lo que están utilizando?
Okay.
It's more
So,
to catalog the area where we're being, yes.
So perfect. So what we'll do is, once you address the pulmonary vein and the antral regions, we'll switch to the cryo lab for a couple of minutes.
Okay.
And talk to Fermin, and we'll be back with you in about 15 minutes. Is that okay?
That's fine, yeah. We already had done the pulmonary vein. We can give you the recording if you want, but we already had done the pulmonary vein.
Yes.
And the posterior wall.
But what will you be doing for the next part of the procedure?
We're going to try to, I'm going to try to kind of address the appendage and the CS.
Okay. So that's good. It'll be interesting to see the data from that. So we'll come back to you in just a little bit, Andrea.
Okay, perfect.
Okay.
Can we switch to Lewis, please? To hybrid lab. Yep.
So change, the cycle is prolonged and change. I don't know if we recorded the transition. What is the cycle now? As compared to...
Mírame las longitudes permanentemente, por favor.
So look at this electrical.
Yep. Do you think, I think this is... Sorry?
Can we go off of this? Okay.
318. 318.
318.
Show me Marta, muéstrame la longitud de ciclo en la pantalla.
Okay. Okay, we are back with you, gentlemen, to get the update on the cryo case. Could you tell us what you've done?
Hola, ¿sí me escuchan?
Sí.
Sí, ¿se escucha?
Sí, escuchamos.
Sí, sí.
Bueno,
Okay,
entonces ahora
so then,
lo que vamos a mostrar
right
es
now
el
what we're going to
aislamiento
show you is the isolation of
superior
the right upper pulmonary vein. We are going to be showing
y el cuidado principal que hay que tener
radioscopy
con esta vena
and
y que
the
ya
care that we need
referido
to
con
take with
literatura
this
es la
vein,
complicación más
and it is
frecuente
written in the literature, and it is the most frequent complication, phrenic nerve paralysis. So for us, the best technique, the most accurate technique is 20 seconds after starting the application with a cryo balloon to pace or stimulate the phrenic nerve and see the diaphragmatic capture. There are two patterns of phrenic nerve injury. One of them is that the diaphragm loses contraction force. So we interrupt then the application of the lesion. And the other thing is a sharp loss of the capture of the diaphragm. The second situation, it might be because of displacement of the catheter, and what we see most frequently is a gradual reduction of the contraction strength, contraction force. We're going to show you the radioscopic image, and you can see here the sharp contraction of the diaphragm. You can see clearly, and we can see it also in the intracardiac echo in the eyes. It's a spasm of the diaphragm with a sharp descent of the cardiac image and of the balloon. You can see the venography, complete occlusion, and in this case we managed to isolate the pulmonary vein also after 45 seconds of initiating the lesion. Here you can see in the monitor the lesion of the electrogram, in the electrogram at the beginning, the fractionated electrogram, and a profile of the ventricle, which is the second electrogram that is separated by the isoelectric line. After we applied the lesion, there was a single potential with the far field of the ventricle. We are going to be showing it in a couple of seconds. This is Vidal, Fernando. Two questions. Where do you like to place the catheter to stimulate the phrenic nerve? Well, that's a very good question. I'm showing the electrogram after the isolation of the right upper pulmonary vein, and you can see as a single potential and all the fractionating of the vein has disappeared. The position of the catheter needs to be as distal to the balloon as possible in order to assure conduction during the pacing. It cannot be too close or underneath the balloon, or else it will not assess the conduction over the entire phrenic nerve. So we go to the subclavian region, and with a slight torque, we stimulate from the subclavian region. Yes, sometimes you can place the catheter even inside the subclavian vein, yes. The subclavian vein, bringing it up to the subclavian vein, and you can leave it there still, and you can pace there. Yes, it's more stable. Yeah, but the idea is to have it as close as possible to the balloon so that the entire trajectory of the nerve is assessed during the application of the lesion. And where do you leave the ICE catheter when you're doing the right side? We leave the ICE catheter in the same position. We check the position of the balloon. We leave it there monitoring, and we see the increased echogenicity of the balloon during the lesion, and that's all. Okay. And every now and then, if you want to stop doing fluoroscopy, if you bring it a bit lower, you can see the diaphragm without having to use fluoroscopy. Exactly, that is so. Yes, of course, our main technique is palpation, but as you can see, we can use echo and we can see in capnography with the change in expiration. A question from the room is, how do you manage the risk for the esophagus? Well, we use temperature thermometer, and we tolerate lowering of temperature down to 20 degrees with all the limitations um, of this methodology, because when it reaches minus 20, it's late arrival and it continues to descend. And because the thermometer is very focally placed and many times it doesn't take the temperature at the level of the esophagus. But we use the same strategy as with radio frequency. All we do is assess the descent down to 20 degrees centigrade. So in that case, in this case, is this local anesthesia or general anesthesia? No, in this case, we're working with general anesthesia, and all of our cases we do with general anesthesia. And I cannot see the esophageal thermometer. No, 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 we are not using it in this case. The other point about the thermometer, as you said, sometimes the temperature is a false guide, because failure to see a change in the thermometer might be that we are measuring at a different level. Yes, that is so. In my own experience, I use it more as a guide to know where the esophagus is, rather than measuring the temperature itself. And when you look at the two X-ray indices that the balloon is very far from the thermometer, you can be more reassured, and you can apply colder lesions and longer lesions. If you are seeing two indices and they tell you that the esophagus is right close to the balloon, that is where we need to be careful. And we need to shorten ablation time in order to do it properly. The question is, how long is the ablation, and do you apply a second lesion or not? Our practice to disconnect a pulmonary vein in the first 45 seconds, we apply just one lesion, 240. By protocol, what the company recommends for the use of the device is to use two lesions of 240, and there are some publications with very good results using 180. But our practice depends on the degree of effective lesion, and early disconnection or dissociation doesn't require the second application. So in that case, we use just one. In this case, we have done two applications per vein, and that was the protocol that we used. I don't know if you're seeing it in the room. Are there any questions here in the room? Any questions from the audience here? No, they're all happy. Here I'm showing you the algorithms that have been published, where we can see if the time of disconnection is very good. As you can see in the to the left, you only use one application. Well, and this is the protocol that we use. And on follow-up, a one-year follow-up, the result of recurrency doesn't change. So I think that one lesion is more than enough, especially since the time we have had second-generation balloons where we have doubled the number of injectors. The injection is much more effective. So it's too much to use the two applications. When we had good temperatures and good occlusions with first-generation devices, it was more difficult. But now the balloon cools very quickly and very well, and therefore one lesion is more than enough. Well, excellent. Thank you very much, Fernando. Thanks to you.
Congratulations, guys. No other questions.
There were no questions. No.
Okay. So we are now going to switch to Dr. Fermín Garcia's case.
El doctor Fermín García, por favor, pasamos a esa sala.
Fermín y Miguel, ¿están con nosotros? Fermín. Estamos conectados. Sí. ¿Nos escuchan?
Doctor, ya vamos con ustedes, los voy a poner en vivo.
Ok, enséñanos, ponnos la imagen de fluoroscopia. Hello, Chief, can you hear us?
¿Nos escuchan?
Sí.
Ok. Dale.
Dale, Fermín.
Hello.
Yeah, we can hear you guys very well.
Los estamos oyendo muy
We
bien.
can continue in Spanish.
Pueden continuar en español, por favor.
Para yo no oír a Diego, estoy oyendo a Diego. Estoy oyendo la híbrida, que me la traigan aquí.
He's asking the hybrid to be turned off because he can hear
Yeah,
the.
we can hear you very well. Could
Okay.
you give us an update where you left off?
Yeah,
You were trying to.
Demostramos, ya, nosotros demostramos
We demonstrated that there was conduction in the isthmus, so we decided to perform the injection of the vein to try and obtain a blockade. And what we are going to show you are the steps to be followed to perform the injection. And I'm going to let Miguel to explain it to you, and then we will show you the results. Okay, you can see under fluoroscopy, the balloon, in this case, it's a 15 millimeter long balloon. It's longer than what I usually use, and the fluoroscopic marker is in the center of the balloon. We are seeing contrast in the Marshall's vein. We are injecting contrast, and we can see that there is staining. It's distal in the upper part of the left atrial ridge. This was the first injection. During the first injection, where we have intermittent blockade, the electrograms with intermittent blockade. The injection was done during pacing of the appendage, and here we see the first effect of the first injection. As you can see, the distal CS showed two double potentials with a late and an earlier component. We need to consider the first injection was very distal, and we were not expecting to obtain great effects with that first injection. Everything was well tolerated, so the next step was to deflate the balloon and pull out the balloon 1 centimeter, inflate it again, and again a contrast injection in Marshall's vein, which is the one you see there. Marshall's vein becomes rather opacified. There is some opacification in that area, opacity of that area, and that is where we applied the second injection. And now we're going to show it live. Please run it live. The second injection, we need to see it live. Let it run, please. We are injecting right there. It needs to run. It needs to run, Diego. Please, in the room, you need to turn on the live screen. You are on the wrong screen. You need the live screen in the room where the audience is. No, Giancarlo, the live screen. Leave it as it was. The X-ray and the polygraph live, because you're showing the wrong screen. We need the live screen. The live screen, Giancarlo. No, that's not the one. From the beginning where we start injection number 2. Yeah, we're pacing there. Right there, we were pacing during the injections. You have to go back somewhat. It's not running. You need to show the review. Okay, then do it manual. We are injecting, and as we inject, stop. You can see how conduction changes. This was 8 seconds after starting the second injection. As you can see, Chief, can you see this well? Sí, está muy bien. And you can also see that since we are pacing, we placed the wire through the sheath outside the balloon, and you can see how the wire is later epicardically. You can see the wire, the electrogram in the wire in the vein region as well. Yes, this is an innovation by Dr. Garcia. We placed the wire in parallel to the balloon so that because we wanted to record signals through the wire as we were injecting the alcohol. You see how the conduction changes, and then after completing this injection, we can do it live because we're going to show live the bidirectional blockade. We need to show the electrogram screen live, please. And so pace, the lasso. Space the lasso. Okay, we still have a blockade. The proximal CS activates before the distal. We want everybody to see it the same. Here you can see it. You can see now that there is a blockade by pacing the lasso, and now pace the coronary sinus 1, 2. Pacing. Coronary sinus 1, 2. And the lasso now activates late, but the wire, it's after the ablation catheter. Before, when there was conduction, the wire was before the ablation catheter. Now the wire is after the ablation catheter, which means that there is much more epicardial delay, and we can see that there's complete blockade. After obtaining complete blockade, we pulled back. Only the NAVEX screen, please, only the NAVEX screen. We performed a third injection, and then we repeated the voltage map. And now we are going to compare the two voltages. The one acquired at the beginning, basal, the baseline, and the second one. And you can see the scars where we expected them to be. There is no doubt that there's a change. It's not beyond what we expected. The scar corresponds to the anatomical location of Marshall's vein and the surrounding tissue. And what we're going to do now is to complete with RF the endocardial ablation in those areas where there's still some visible electrogram. Even if there is bidirectional blockade, I always like to retouch if need be in order not to leave anything in the endocardium that might be a surprise later on. So this is mission accomplished. Are there any questions from the audience, Chief, or whoever is at the microphone?
¿Queda claro el bloqueo?
Is the blockade clear? Were you able to see it clearly in the room? Would you like us to repeat any images? It's important that you clearly see the electrograms. Let's see the electrograms again, where we have the blockade. Let's see the review screen. And the last one. So we should clearly see the stimulation or the pacing of the coronary sinus 1 and 2, distal to proximal. And the last activation is in the guide wire, which is blockade, and this is a stimulation of the coronary sinus, and this is during injection. This is the second injection, as Miguel said. The first injection is more proximal towards the fox of the vein, and we can clearly see the transition of pacing in the distal to proximal lasso, ablative transition, and in the third beat, proximal to distal conduction of the coronary sinus with finally pacing of the cardiac vein in the end. Any further questions? Good morning. I have a couple of questions. Could you explain the technique about the alcohol injection? How do you do the alcohol injection as such? What's the technique? And number two, what should you avoid in order to prevent complications? Very well. As you saw, the technique has several steps. You have to go into the coronary sinus. You have to identify Marshall's vein with contrast media with a Lima catheter in the coronary sinus so that the tip of the Lima catheter is posteriorly oriented. Here we identified Marshall's vein almost immediately. The second step was to pass the angioplasty guide in Marshall's vein, followed by the balloon. The balloon is already preloaded through the wire, so when I get the wire inside Marshall's vein, I can advance the balloon, and then the balloon is already inside the Marshall vein. I remove the wire and inject contrast media in the balloon to see the Marshall vein anatomy. And with the balloon in the most distal aspect of Marshall's vein, I give the first injection, 1 cubic centimeter of alcohol administered over 2 minutes. Then I deflate the balloon, pull back the balloon 1 centimeter, inflate again, inject contrast again, and then another alcohol injection, 1 cubic centimeter for 2 minutes. And this is how I do it sequentially, up to 3 or 4 alcohol injections. In this case, only 3 because the vein was not that long. The idea is to start from distal to proximal. There are alcohol injections then at several points along the Marshall vein. What about complications? The most frequent complication is the dissection of the coronary sinus with no consequences in my case. There was just a dissection of the coronary sinus. We left the patient in observation. Since we are in a clinical trial, we had all the necessary supervision for the patient. We had to stop the procedure just to observe the patient, to report to the ethics committee and all that formalities. But we haven't had any procedural complications beyond the dissection of the coronary sinus. We had patients that had pericarditis, inflammatory pericarditis, 2 out of 100 patients. It was a subacute condition that developed 2 to 3 weeks later. But the truth is that now we are doing a randomized clinical trial and we are studying adverse events, and they are no different from the control group. Group of patients only with ablation of pulmonary veins versus the alcohol-treated group. And we haven't had any events, any adverse events associated with the procedure. Obviously, if you dissect the coronary sinus in an unfortunate manner and you have bleeding, well, you may have bleeding just as in any other procedure. Do we have any further questions from the room? Well, one more point that I would like to mention. The use, particularly in this area, I believe that with what we just saw in this case, it's very impressive, the blockade, but I think that there has to be an endocardic ablation component, and the basis for a good endocardic selection site is to pay attention to counterforce and to the catheter when you do the lesion. In this case, we are using CUPA. And can we have the intracardiac ultrasound image with NAVIX? And you can see that at least we have 10 grams of force with a contact marker directed to the area. It should be directed on the NAVIX screen. An intracardiac echo in the lower segment, you can see the lesions very clearly. Could we have the intracardiac ultrasound live in our room? Yeah, I would like to see the live intracardiac ultrasound with NAVEX. 2 points to mention. One, you can see in the intracardiac echo the echogenicity of the ridge, which was not so echogenic at the beginning of the case in this area. This can be the result of alkalization of this area. And by doing the ablation in this area, we get this ice image. You can see the origin of the posterior aspect of the lower left pulmonary vein, and here you see the coronary sinus in the mitral valve, and this is the area that has to be covered in detail. When you do the ablation, it has to be done very detailed, at least 10 grams of force with the vector and the marker oriented to the right area when you do point-to-point ablation. And at the same time, we can see in the ultrasound good contact with a force of at least 10 to 20 grams with constant irrigation. In this case, we are using cool pad. We are using 30 watts, a contact force of 10 to 20, trying to maintain the catheter stable in an area, and an LSI of 5.526, and we move the catheter further distally, which is the most important part where you can have a connection, and we can clearly see in the ultrasound that this is towards the mitral valve. And here it seems that we are in the ventricle, but that's not the case, because in the ultrasound, clearly we are behind the mitral valve. This is really what marks the most distal aspect of the mitral isthmus. And you can clearly see it in the ultrasound. And this area, it's also very important because probably this is the area with greatest contact. In the X-ray, can we see the live X-ray, please?
La relación de donde estamos
In the
haciendo la-
X-ray, the relationship where we are doing the ablation, you can clearly see. This is where we are making the ablation with the catheter towards the Marshall vein. And it's in the box of the Marshall vein. We are doing ablation downwards endocardically in order to do a transmural lesion throughout this area. Do you agree, Miguel? Do you have any further comments? Yes, it's important to understand the clear message. Alcohol in Marshall vein rarely will help in bidirectional blockade on its own. It will never accomplish bidirectional blockade because of one reason. The coronary sinus is an atrial structure. There is still a little bit of atrium and the balloon occupies 15 millimeters in this case. Therefore, there is part of the tissue in the mitral isthmus, particularly in the most annular area, that the alcohol can't contact. So this is important to be emphasized. People may say that alcohol cures everything, and that's not the case. It's important to understand the contact of alcohol. So what's the right timing to do the alcohol injection in Marshall's vein? If you don't achieve blockade, what's the management? Well, the indications are yet to be established. This is a technique which is experimental. Right now, we are doing a clinical trial. My practice is if a patient comes after fibrillation ablation with flutter, and it looks to be left flutter, then the patient is asked to give consent for alcohol injection. First, an endocardial lesion with radiofrequency. If I get bidirectional blockade, that would be the end of it. If not, I inject alcohol in Marshall's vein. But certainly this is an adjuvant technique. As a second procedure, yes, the first procedure, I only do it in randomized clinical trials. But what would you do in the first procedure if you cannot get the blockade? Well, if we are out of the clinical trial, I can do it. In principle, if I can't get blockade and I haven't talked to the patient about the alcohol, we have to finish at that point and the patient should have to come back later. Not all the mitral isthmus that are without block will give rise to flutter. Well, if there is flutter, well, it can be a patient with flutter. Well, it's very rare. It's not frequent at all. In principle, I do this as a second-line procedure. And the first procedure, we have our randomized clinical trial, 400 patients, where we are going to study this. But for the time being, it's only for the second procedure. That depends on how much you like the technique. I love it. I love my technique. But I don't waste time burning and burning and burning the mitral isthmus. If I do a lesion and I have low voltage in the mitral isthmus and I have not achieved blockade, the next step would be to treat the coronary sinus. And if I don't get blockade, I would say that of the second procedures, in 30% of the cases, I administer alcohol. But that's also because I am passionate about this procedure. A question for Fermin. In order to have that projection, well, let me show you. Here, we start from the entrance. This would be the home view. Please give me eyes only on the screen. Yes, this is what we call the home view. Here you can see the tricuspid valve. I would like to show the pointer on the eyes. This is the live home. Here you have the right atrium, the tricuspid valve, and the right ventricle. We do anteroflexion, you cross over to the right ventricle, and there you start doing clock. This would be the posteromedial muscle, the anterolateral muscle, and then you pull backwards. We pull backwards just a little bit. Let me put it back again. Here, so you pull backwards. Here you have the left atrium. In the back, I am showing the ablation catheter. I am moving here the ablation catheter. You can see it moving around. That is the superior pulmonary vein. And you can see the ablation catheter coming in. This is a counterclock turn. And this is the ablation catheter. I'm placing the tip on the mitral valve. As you can see clearly, the ablation catheter, the tip on the mitral valve, as you do clockwise movement, you can reach the most posterior aspect in the ridge before going into the lower pulmonary vein. And the view basically is a bit of clockwise and counterclockwise from the outlet tract or from the right ventricle. Now show me a fluoroscopy image now. This can give you an idea of the catheter location. The fluoroscopy image with eyes image. So here you can see live fluoroscopy. You can see the eyes catheter crossing the coronary sinus in the outflow tract under the right ventricle. And this is the eyes image obtained from that catheter position. I don't know whether this explanation has been clear. Yes, excellent. Thank you very much. I think that we are ready to go to the next room. Now we are going to Andrea's room.
could give us an update, and then we can. We have finished the other two cases,
Okay.
so we'd love to get an update from you.
So we're going to show you the esophagus. I think you had some discussion before. And then before, when we were ablating, the patient went in fib, different type of flutter. So I want you to comment about what is the relevance of fib and flutter while you're ablating. And so based on so we went eventually from fib to stable flutter. That is clearly left-sided, atypical, probably perimitral. Although we have been ablating inside the CS now for about 5 minutes without much effect. So, why don't you comment about what you think the relevance of flutter and fib, based on many algorithms that people use today, like the rotors. This would have been the equivalent of a termination, correct?
That's true.
Yeah.
So we're going to show them some slides in a little while about that whole controversy about the fact that we don't have a good understanding of mechanisms. So that's why your ablation strategy becomes interesting, which I presume is going to be very anatomically based. Is that correct?
So it's anatomically based, but at this point is more driven by the experience that we had with similar patients. So in general, we try to do the posterior wall, the pulmonary vein, and then we cardiovert and do isoproterenol. But this is the guy, as I mentioned before, mechanical valve, very, very large atrium. So we cannot go by default to the site that we know by experience as the most common trigger site, which are the CS and the appendage. So we're kind of done the CS and ablation along with the CS endocardial. Now we're doing the epicardial stuff. So we are inside the CS. So it's anatomical, but it's driven by what we have learned over the past several years about the trigger source in this type of patient, the trigger source location. Okay, we just went in focus.
Yeah.
Did
you see that?
Yeah, Andrea, can you make one little comment? You've worked in the atrium, the CS.
Yes.
In your experience, especially with patients who have two mechanical valves,
Yeah.
sometimes the surgeon may leave behind a portion of the appendage stump. Is that something that you sort of look for in these cases?
Yes, absolutely. Actually, we've seen even when you try to cross the appendage with a clip, we have seen that almost 95% of the time there is a stump that is actually electrically arrhythmogenic. So epicardially, what the surgeon do with the appendage is not, it might be okay. It might be okay for stroke prevention, if it is, but it's not okay from an arrhythmogenic point of view, because actually the stump, in our experience, is probably more important than the body. If you think about embryologically, actually the smooth portion of the appendage has some relation with the primordial pulmonary vein. It's a little bit like the posterior wall and the rest. That's a part of the appendage that is related to the primordial pulmonary vein. More than the trabeculated part. The trabeculated part had a completely different embryologic origin. So, yeah.
Have you in your experience, have you also seen any SPC sources?
Yes, we do the SVC in everybody. You're talking about this specific patient, or in general?
Not with this patient, as a general comment for mechanical valves.
We have seen in the right atrium more tachycardia than other patients, probably close to the extension of the atriotomy to open the septum. So it's kind of, in general, a little bit below the SVC, more septal. We've seen some focal tachycardia in that area, but the SVC, we've seen everything larger. So eventually, once we come back on the right, we're going to isolate the SVC in this patient.
Sure. So Andrea, one question for you. Do you want us to come back to you in about 20 minutes? And could you give us a wrap up at that time?
I want to show the esophagus dislodgement.
Chief,
This is not the ideal patient because patient with previous history of surgery, cardiac surgery, because of the scar tissue,
Yes.
they usually tend to move less. But in this case, actually, there was...
Wait. ¿Pueden mostrarnos la flora, por favor?
We are able to move the esophagus away from the right pulmonary vein. Even in this case, which, as I mentioned, I was not... actually, you can see that. So you can see how the esophagus moves towards the left from when you were ablating the right.
Yeah.
Which is unusual. Usually in this patient, because of the scar from the surgery, we are not able to achieve this kind of movement. But this is we're able to. So I think it's important to show you. One thing that is important for people to understand is that moving esophagus, the way you see it here, does not necessarily equate to really moving the esophagus.
Yeah.
You could actually push the wall, and the other side of the wall is still where we are ablating. So we're actually doing a study in Austin where we inject contrast before we advance the stylet, and we kind of look at that. And I have to say that most of the time there is actual movement of the esophagus, but there are cases where, and that's something that people need to be aware of, there are cases where you just stretch the wall, but the other side of the wall still remain where you are ablating. So I think you need to do some imaging with contrast to be 100% safe, confident that you're safe when you do this maneuver.
So you think it's going to be 50-50 for patients with post-surgery? Is that what you're saying?
No, I'm talking about in general.
Okay.
In patient post-surgery, I'm surprised of how much motion we were able to achieve. Our experience, we don't even use it because our experience is that you very little. I'm talking about in general, patient no history of surgery, when you advance the stylet, the fluoroscopic impression of the esophagus need to go along with some degree of contrast injection to make sure that you're not just stretching the wall, you're actually moving the esophagus.
So Andrea, is there a way in which can someone show the esophageal instrumentation?
Yes.
In the view of the lab? So if you can switch to the camera of the lab, maybe they can just show this to the audience.
La cámara desde el techo, por favor, y enfoquen a donde está la sonda.
Oh, great. Thank you. That's.
Yo creo que va mejor desde.
I think it's better from the camera that is towards the head of the patient. Puede tomar otras.
Sit on the groin so we can see it.
¿Tienen otra sonda?
Well, we are going to show you now.
So Andrea, could you just grab another one in your hand and just show it?
Danos un tiempo.
You want to use this one or do you want to get another one to show that to them?
Yo tengo otra acá.
Okay, let's remove it. So we're going to remove this one.
Right now.
Do you want to show the X-ray?
Yes.
Yeah.
So, wait a second.
Pull the
Los fluoroscopia, por favor.
We would like to have the fluoroscopy and the camera. Yes, that's exactly it. We are below the coronary sinus. I am going downwards to create a right curve. We can see the upper right veins and the lower right veins. And I want to use the left vein. I'm going to move it in this sense in order to work with the upper and lower left veins. I can also fold these. We need to better focus the camera, please. Sí, Andrea, esto está ayudándonos mucho. ¿Tienen alguna pregunta sobre lo que están viendo del público?
As I said, this year you tend to see less motion because of the surgery. Typically, you see a lot more, especially when you turn.
No, but what is impressive, Andrea, is the fact that it moves as much as it does despite surgery, right?
Yes, yes.
Yeah, exactly.
It's kind of unusual in the Okay, do you want to...
So, Andrea, we'll come back to you in about 15-20 minutes, and you can give us the closing
Chief,
comments.
Chief, before moving, si se dieron cuenta, el flutter revirtió.
When Andrea was explaining the coronary sinus, did you see the change to sinus? So here, the esophagus was turned around. Can you see it?
Are we connected? Are we connected with the audience?
The probe moved the esophagus to the left. If you want to go to the posterior antrum of the right veins, and you can also advance the probe of the esophagus. We are not necessarily moving the esophagus. We could just be stretching the esophagus, but you need to monitor the probe and use contrast to see whether the esophagus is moving or not. Bueno, vamos.
I'll say 15 to 20 minutes, and then you can close up.
Right.
Okay.
Thank you so much, Andrea. Thank you, Louis.